my background is I used to be a liver surgeon once upon a time, and because of that I came across patients with metastatic ocular melanoma, and because of that I got involved with Ocular UK. Declarations of interest. Does it do this? It's the down button. Yay. So not too many. I am chairman of trustees. And once upon a time, Delcath used to take me out for the odd dinner. They've slightly lost interest in me at the moment, but there we go. So I'm talking about metastatic disease and kind of what happens next. Metastases, secondary cancers, stage 4 disease, you all hear these terms. Basically, it means the cancer has spread. It's moved out from its original primary site and it's gone somewhere else. And we have to ask how that happens. Well, with different cancers, it works in different ways. But with ocular melanoma, uveal melanoma, it's usually down to blood-borne secondaries. So tumor cells have escaped into the blood circulation. They've gone somewhere around your body, and they're causing trouble. Well, why do they do it? There's an intrinsic invasive nature of cancers. If your cancer isn't invasive, it's not cancer. So that's the nature of cancer. It has to have that inherent ability to invade into other structures. And if it doesn't have that, it's not a malignant process. It's not cancer. And then there's a very complex interaction with the body's immune system. And then there's also anatomical considerations. So organs like the liver, they act as big filters. So much blood goes through the liver, and it's got a really rich capillary base that it just sieves out cancer cells that get into the bloodstream. And then the immune system in the liver is a little bit different from the immune system in the rest of your body, because the liver is designed as a filter for blood from the gut. And so the immune system there is actually tolerant of a few things that might normally escape from the bowel and get into the bloodstream. And so it's just got a slightly different immune environment. And so it enables cancer cells to thrive in that particular filter from certain types of cancer. We don't always understand all of this. We're learning more and more. Different cancers like different organs, different places that the cells end up and that they thrive. You know, why is it that kidney cancer likes the lung, bowel cancer likes the liver, prostate cancer likes the bone, cutaneous melanoma likes the brain? You know, why all these things? Lung cancer likes the adrenals. You know, there are just patterns that we see with different cancers, and we don't always understand exactly why. Yeah. Right. But ocular melanoma, as you all know, has a tendency to go to the liver. So this is pretty old data, but I don't think anything really has changed. That's a PET scan next door showing somebody who's unfortunately got really widespread disease dotted all over the place. So, secondary cancer. The question is, what happens next? It's a bombshell, first of all. You've had those words said to you. And then it's immediately followed up by things that the doctors want you to have done. So, endless things, blood tests, ultrasound, CT, MRI, PET, any of those may be occurring. They've all got different value and they've all got different roles. And the process is known as staging your tumour. We're trying to stage the tumour and we're also trying to assess you, trying to work out what you're fit for, what your body's able to take, where the tumour's spread to, and what the extent of it is and what options that we then have to offer. Is it disease that's only in the liver? Is it disease that's spread around elsewhere? Is the pattern of spread diffuse little dots all over the shop? Or is it something that we call oligometastatic disease? So a bit of a mouthful, that one. But oligometastatic means that you get isolated dots that sometimes can be quite big lumps, but they crop up randomly you might have 4 or 5 metastases spread around different organs in your body, rather than having a very diffuse pattern. It's quite uncommon with ocular melanoma, but it's a really important subgroup to find because there's a different way of managing them. So blood tests, one of the ones that you'll definitely have will be liver function tests. I'm sure you've all had liver function tests done at various times. Liver function tests can be abnormal for hundreds of different reasons. So whenever we look at liver function tests, it's always a question of assessing, actually, what's your background health like? If you're overweight, if you're diabetic, your liver function test may well be abnormal anyway. If you've got gallstones, your liver function test may be abnormal. There are some inborn errors of metabolism that people have. There may be somebody in this room who's got Gilbert's syndrome or Gilbert's syndrome. Anybody heard that? No? No? Okay. Normally in a room with this many people, there'll be somebody who's got it. But it just gives you abnormal liver function tests. So lots of abnormal liver function tests are not significant. You've always got to understand why they're abnormal. They can be abnormal because you've got tumours pressing on the bile ducts, causing obstruction to the flow of bile in the liver. It can be because you've got a large volume of tumour, in which case it can be impairing the function of the liver. Liver function tests come in a couple of forms. They're the ones that just reflect the enzymes in the liver. Then we also look at how the liver is performing and doing its job. So the liver, one of its main jobs is to make proteins. And we look at a protein called albumin in your bloodstream to see what the level of that is. And we also look at the clotting proteins that are made by the liver. And we do a test called the INR, which tells us how thin or how thick your blood is. So if you're really struggling, if you've got a lot of disease, if you're in a bad state, your liver function tests can be very useful, telling us that actually things are not good. But minor abnormalities in the LFTs are so common that they can be very hard to interpret. So being told, yes, your liver function isn't normal, well, you've got to find out, is that a minor abnormal? Is that something that you've been living with for the last 20 years unrelated to your cancer? Or is that because your cancer is causing a problem? If your liver function tests are going significantly abnormal, particularly if you're starting to become jaundiced, then that can be a significant problem for future treatment options. But most people will find that liver function test abnormalities are minor and may be difficult to know whether they're related to the cancer or not. One of the things with blood tests is when you first look at them, you have a snapshot in time. And it's trends that we're looking for a lot of the time. So if you've got a problem with your liver function that you've been living with for years, and we've only seen it for the first time, we don't know that. So it's sometimes serial blood tests that can be useful to see what's happening with the liver function. If your liver function's off, an ultrasound can help, particularly looking for obstruction of the bile ducts. CT scans, really helpful. They're very good for looking at anatomy. And so they're good, really, from most people having one would have one of the chest, the abdomen, and the pelvis. Very good for staging, looking for secondary cancers in the lungs. With ocular melanoma, they're a bit less good. I seem to be going to sleep here. They're a bit less good for looking at the liver. They're good at finding big lumps, but they're not very good at finding small lumps. So if you really want the most sensitive test for looking for liver secondaries, then it's an MRI scan. And there's different ways of doing MRI scans. With any scan, there's a degree of art and there's a degree of science. So some of it is down to the operator. So with an ultrasound, it's incredibly operator dependent. It's a real skill to be brilliant at ultrasound. And actually, because the emphasis these days is so much on CT and MRI, the radiologists coming through are probably less skilled at ultrasound than they would have been 10 or 15 years ago, because the emphasis in their training has moved away from ultrasound. as CT and MR have become so much more sensitive and so much more available. Again, if I asked for a scan 20 years ago, for anything almost, it would have been an ultrasound, just because of availability. Now, because CT and MRI are so quick and so available, it's CT and MR that you're using as your first line rather than ultrasound. But ultrasound does still have its value, but very operator dependent. CT scans and MRIs are very reproducible. MRI in particular has many different sequences that they can do. So you might be in an MRI scanner for 20 minutes, 30 minutes. CT is very quick these days and can be done in 90 seconds or less. But an MRI, 20, 30 minutes, and they might have 20 or 30 different sequences that they look at, each of which has generated 50, 100, 200 pictures of your liver and your tummy. So there's an awful lot of images to look at from one of these. And you've got to pick the right sequences, and you've got to have the right settings to know that you're actually looking at the right thing. PET scan. PET scan's very good for looking at areas where you think there's tumour, but you're not sure. And it's looking to see, what a PET scan does is it looks for metabolic activity. It looks to see whether the tumour is active, usually taking up glucose. Most of the ones that we do at what's called an FDG PET, which is where we've got a radioisotope attached to glucose, and we're just looking to see for areas of metabolic activity. And cancer is metabolically active because it's growing, it's active, and it's causing mischief. And most cancer relies heavily on glucose, as do most other tissues in your body. So they suck up glucose and they suck up the radio-labeled stuff, so you get that lighting up like a Christmas tree. So all of this is giving information, blood tests, scans, and also there's an assessment of you. So doctors shouldn't just be relying on tests. They should be looking at their patients, examining, talking to you, finding out what you're like. Can you climb a flight of stairs? How far do you walk the dog? Are you able to get around the house? What's your level of independence? And then what do you want? What's your aims and your goals? Everybody's different. There's a lot of things that we can treat, but sometimes patients say, actually, I don't want it. I don't want anything. I've had my time. So we have to be able to respect that as well. My mother she's 83 with Alzheimer's. She's got enough capacity to know with her tumour that she's got. She just says, I don't want anything. I've had enough. And you've got to respect people's wishes. So decision making. How do we go about that? Well, you need a multidisciplinary team meeting, but it's not the only place that you can have a decision made, but an awful lot of decisions these days for cancer patients are made in MDTs, multidisciplinary teams. So what do you need in an MDT? Well, there's a huge range of specialists. You need basic administrators, an MDT coordinator. You should have nurse specialists in there. You should have pathologists. And then you've got those who are the active deliverers of the oncology care. And for different specialties, you need different groups in there. For some things, you'll need a gastroenterologist. Sometimes you'll need a general surgeon. But the main people who are delivering treatment for cancer fit in these four groups. Medical oncology, which is delivery of chemotherapy, including immunotherapy. Surgical oncology, which is surgeons who are cutting things out or bypassing or looking at ways around tumours. Radiation oncology, also known as clinical oncology in the UK. And then interventional oncology. And this is a group that people tend to forget about. These are the radiologists who deliver therapeutic arms of treatment. And that's been a massive growth area. In fact, I'd say all of these have been growth areas over the last 2 decades, 3 decades. Medical oncology, they've got so many more strings to their bow, with immunotherapy having come on board. Surgical oncology, well, we've got so much better at removing things in awkward places that's opened up many more doors and avenues of treatment. Radiation oncology, well, we've got different ways of delivering radiotherapy. It's not just a big external beam linear accelerator in a bunker that you have to go to 30 times and get fractions of radiotherapy. We can give radioactive particles in different ways, in different places. We can give radiation during surgery. Interventional oncology is a field that didn't really exist 20 years ago, but it's been an incredible growth area. So this is things like putting probes into tumors to ablate them under X-ray guidance, or it can be delivering particles into the bloodstream that get into the tumors themselves, block off the blood vessels to the tumors and deliver chemotherapy. And it can be things like Delcath, isolating the liver from the circulation, flooding it with chemo. So there's all these different therapeutic arms that are available for different types of cancer. And although I'm sure you've heard many people say already, well, there's not much evidence, and for a lot of these there isn't much evidence, but what there is if there's a willingness and people are prepared to try, then there are options that can be taken. The evidence isn't always there in terms of massive randomized controlled trials, but what we are finding is that by having a bespoke approach to patients with advanced cancer and delivering treatments that are individualized to them, considering all the options, patients are living far longer than they ever used to with this disease. So whilst the bald statistics are not stunningly good, whilst the trial evidence isn't great, actually we are managing to make a dent in this tumour at an individual level for people who are in the right place, getting the right options offered to them, and prepared to give it a go. And it doesn't always work. There's lots of different types of liver lesions, and if you've got a scan telling you you've got stuff in your liver, you need to know, actually, is this primary disease from the liver? Is this benign liver stuff? Are these secondaries from my eye cancer? Could these be secondaries from something else? You know, if you're with ocular melanoma, the risk goes on not just for 5 years after you've had your eye treated, it goes on for 10 years, 15 years. And we do still see patients a long way down the line getting secondary disease. And if you're 10, 15 years out from your primary, you might be reaching the point where actually those secondaries in your liver are equally likely to have come from something else. You could have developed bowel cancer. You could have developed ovarian cancer. You could have developed something else. So we always need to be sure. There are some characteristics that we can tell on MRI sometimes that give us a really strong steer that this is melanoma. Other times it takes a biopsy, which might be done under ultrasound guidance, or it might be laparoscopic under general anesthetic. We do a keyhole operation to look in, and very often if you look at the liver in metastatic ocular melanoma, it's really, really clear because the secondaries are black, because they're full of melanin, the pigment that you also get in moles. So if you see those black dots like iron filings all over the liver, then you know you're dealing with your metastatic ocular melanoma. But there are many other things that can fool us. I've had patients where we've ended up doing operations to remove liver adenomas, which are primary tumours of the liver. They're benign. So it's great news if you've gone from having what we think is metastatic ocular melanoma to having surgery to remove a benign lump. The benign lump, well, it might be one that you could have lived with, but for goodness sake, it's better to have that diagnosis with it out and in the bucket rather than thinking that it was ocular melanoma. We don't get it wrong that often these days, but it's probably still about 5% of the time. Liver resections for rare tumours like ocular melanoma will turn up benign disease instead of what we thought. The list of what it can be is so long. I could tell you about von Meyenberg complexes and sclerotic hemangiomata, but to be honest, that's the kind of stuff that is of great interest to liver pathologists, but it's just a lot of long words that don't mean much. The bottom line is there's a lot of benign things that can look like metastases in the liver that aren't, and there's a lot of other tumours that can give metastatic pictures that could be ocular melanoma but aren't, and you've just got to know what you're dealing with so you can get the treatment right. A question that's often asked is, do all centres offer the same treatments or have the same expertise? Well, for some tumours that are common and are very, very standardised, you'd say yes, actually, there's an awful lot of centres that do the same thing. But for rare tumours, that's not the case. There's 135 acute trusts in the UK, of which I think there's about 32, 33 have got liver surgery centres. If you haven't got a liver surgery centre, then you probably haven't got a liver interventional oncologist. So 102 or so of the trusts in the UK don't have the basics to even start talking about treating the liver. But out of those 32, 33 liver centres, unfortunately, there are very few that actually got a specialist interest in secondary disease from ocular melanoma. In fact, it's only 4. What do I say? 33 liver units in the UK, but there's only 4 where you'll find a team that are prepared to sit down with a liver surgeon and a clinical oncologist, an oncologist, and an interventional radiologist, and for those key people to talk about how to manage your metastatic ocular melanoma. So basically Southampton, Glasgow, Sheffield and Liverpool. The London centres, so far, to my knowledge, although they have some of those individuals represented, you don't get a forum where you get those 4 key specialties together to discuss your metastatic ocular melanoma. If you haven't got those 4 key specialties, then you're missing out on a full discussion that covers all the options.
Sorry. From our experience, patients don't always know that they don't have that full unit that are discussing those scans. So, yeah, when people, if something's suspected, unless, what Neil was saying is unless you're actually one of these hospitals, you may not have the full picture.
Now, that doesn't stop people from having discussions outside of an MDT. It just means they haven't got all of those people in the room together. So you can have effective discussions. Somebody at George's or at Bart's, where they don't do liver surgery, might speak to somebody at the Royal Free or might speak to somebody at King's, but it's not quite the same. Having an active discussion between people who are interested, regularly attending and thinking on a daily or at least weekly basis about metastatic ocular melanoma. It's very different from picking the brains of somebody who's an expert in liver surgery but isn't an active member of that kind of team. Another thing that often crops up is the issue of second opinions. And that's always an issue. Some doctors are a bit affronted by the being asked to give to request a second opinion, but it's valid. Why should you ask for one? Well, to get another perspective on treatment options, to get a different range of treatment options, to get confirmation of a difficult diagnosis and prognosis, you know. You've heard something bad. Is that really it? Is that, you know, is there anything else? Is that right? You want to be sure no stone's been left unturned. You know, if you think, actually, I should have another 20, 30 years ahead of me, is that really it? Aren't there any other options? And though often, you know, it's a difficult disease, there may not be. But it's having those discussions, having confirmation, and having a bit of peace of mind that options have been explored. So, do you have a right to a second opinion? Well, the answer actually is no. So, it's not enshrined anywhere. I've written some very lengthy second opinion guidelines for my hospital, and I searched everywhere, and there is no enshrined right to a second opinion. We've made it a right in our hospital, but that's not something that is universal. GMC say it's best practice to facilitate it if a patient requests it or would like it. And you should, but some doctors are reluctant to do so. If the doctor that you're speaking to is reluctant to send you for a second opinion and you want one, ask a different doctor. There'll be other doctors that you're being looked after. It doesn't have to be your oncologist or your GP, but it has to be somebody who's involved with your care. Occasionally patients do self-refer, and that's difficult. If we get patients who self-refer, then the right thing for medical professionals to do is to go back to their GP or their oncologist and say, I've been approached, I would be happy to give a second opinion, would you like me to do so? There's a lot of politics involved with second opinions. At the end of the day, personally, I think we should all just be allowed to do the right thing. And occasionally that means treading on toes, upsetting the odd ego, which can be difficult because these are people that we often want to work with in the longer term and have a positive relationship with, so that we can actually have patients flowing to places where the treatments are available in a free kind of way, without barriers. And upsetting egos and doing things not by the book can create barriers which cause problems for future patients. So it's always very difficult getting the balance. But at the end of the day, I think the vast majority of medical professionals, if they got a clinical case of need presented in front of them, would rather just get on and manage and treat that patient. But it's not quite universal. Forgive me if I'm rambling a little. When should you consider going in a trial? Well, that's a bit of a question, isn't it? I think if you've got an established treatment that is there in front of you, that has got some chance of success, that's got some statistics backing it up, you should take what you're offered. If you're not being offered anything that has got any kind of level of support for it in terms of outcome evidence, then I think a trial is definitely something to be looked at. Trials give you access to things that currently aren't funded by the NHS in some occasions, but trials can also be two-edged, because if we're in a situation where we don't know that anything works, then you might be finding yourself in a trial where one arm of the trial that you could be randomized to is best supportive care, which means probably no active treatment. Now, that's harsh, very harsh, but if we're trying to find ways of generating statistics to prove something's better than nothing, then we have to be able to compare it against nothing. one way around that is sometimes a crossover trial, which is where you have half the patients get nothing or best supportive care, which is a bit better than nothing, but it may not be any effective treatment. The other half get the treatment that's under trial, but when the group that aren't having any treatment then show evidence of progression, you then offer them the chance to switch into the active arm. Problem with that is it muddies the waters for the statistics, because both groups will get the treatment and it will ultimately affect survival. So it can then be very hard to unpick whether the treatment's worked or not. And that is, it's an ethical dilemma that people setting up trials really have a problem with. And it's better if you've got some form of systemic therapy or some form of therapy in the best alternative care arm. But equally, being offered dacarbazine, which has got an incredibly low response rate and a great range of side effects, doesn't sound very much like best alternative care to me. So, unfortunately, it's a bit of a harsh world with trials. But unless we get evidence, it's very hard to push things forward. One of the problems with the Delcath chemosaturation study that was done, I suppose it must be about 8-10 years ago, it was a crossover study. Although it generated some very interesting results, the patients in the best alternative care arm, 2/3 of them or so ended up getting Delcath as well, and they got prolonged survival. So you found it was very difficult to unpick. Different types of trials come in different phases. At one end, you've got phase 3, which will be a randomized controlled trial of new treatment against whatever's the best existing treatment. And then you've got phase 1, which is kind of initial proof of concept, where they're looking at what kind of dosage they might be using in a study. They're looking basically to see whether these are will be the first human trials for a new drug or a new regime. And it won't be a complete guinea pig, but there's an awful lot of this that is based on best guess, having looked at outcomes from mouse models or zebrafish or whatever other trial methodology has been used. So phase 1 trials have higher risk to them, but there again, sometimes you've got a new emerging treatment that sounds like it really ought to work, and if you haven't got any other option, a phase 1 trial might be worth doing. Phase 1 trials, very often, they're not even sure which tumor types this new drug will work for. So it could be that they're recruiting different types. It might be that it's not just melanoma, ocular melanoma. It might be that it's a phase 1 trial recruiting all sorts of other abdominal tumors or secondary tumor types. And they're looking to see where this treatment works. So they can be interesting. Occasionally they can be amazing. But a lot of the time, you're helping us get evidence to know where to get started with a new drug. Pros and cons of trials. Well, there's an awful lot of pros and cons, as I said already. There's the potential to be in a no treatment arm or the treatment arm that you don't want. If you then pull out of the trial, then that skews the results for the trial, which is very harsh, because trials are about treating the herd, not about treating the individual. And although we're all part of a herd, the human herd, it's a bit harsh to think that we're being managed a little bit like the wildebeest on the Serengeti, and it's okay for the lions to get a few. But unfortunately, there is a little bit of that about the approach to trials. And I don't want to knock trials, because at the end of the day, we'd be nowhere without them. We would be back in the dark ages medically. so we need them. But going into them, what you really want is a nice trial of something, an existing treatment that you know works reasonably well against something that might work better. But a lot of the time with ocular melanoma, because we have yet to generate evidence that much works at all, you will find that the best alternative care arm is limited as to what you can have in. You may also find with trials that you're limited to get in because of treatment that you've had already. So like IMCGP 100, if you're offered 2 trials to go into the IMCGP 100 trial, or you're offered to go into the focus trial for chemosaturation, the smart thing to do is to take IMCGP 100 first, because you can still go into the chemosaturation trial if you progress on IMCGP 100, but you can't go into IMCGP 100 if you've been in the chemosaturation trial. So you need your oncologists, you need your team to help you negotiate the options so that you can get access to all the different things that are available and be savvy about it. You don't just want to have the one option that is the preferred one in your centre. You want to know what's out there and what can I get. I can carry on talking forever if you want. So liver surgery, when's that possible? We tend to forget about liver surgery now as we've got all these other treatments that are emerging. But statistically, if you look at it, liver surgery is the one thing that has been shown over the decades to be most effective. But it's only effective for a small group of patients for whom it's suitable. So from a surgical point of view, we want to operate on those where we can remove all visible disease. You've got to be able to leave enough healthy liver for you to stay alive. That's fairly key, isn't it? And you use it when there's not another better, lower risk option. Liver surgery used to be very risky, but for the majority of operations that we do, the risk to your life is less than 1%. If you think chemosaturation, in the trial, the mortality was 7%. We've currently got it down below 1% for that as well. In Southampton, we're coming up to 200 treatments without a death. You need that multidisciplinary assessment if you're talking about liver surgery. The pattern of disease, where are the dots? Is it resectable? Is the background liver good? You know, if you've got cirrhosis behind, if you've got cirrhosis, then we can maybe only take 10% of your liver. If you're, a 21-year-old with a healthy liver, we might be able to take 75, 80%. So are you psychologically suitable as well? It's a big op. You're prepared to go through this. What else is there? Is there anything that we can do to shrink the tumour and make it easier to operate on? We're starting in Southampton to do operations on patients who've had chemosaturation. So we shrink all the small stuff and we're chopping out the big lumps that are left. Why not? But there again, just because you can do something doesn't always mean you should. This is me a few years back. I think quite a few years back. But just because something's difficult doesn't always mean you shouldn't do it either. So it's a technical assessment. Can you get it all out? Think about the blood vessels. Can you preserve the inflow and the outflow? Can you sort out the biliary tract, which is the flow of bile out of the liver? And that key question, is there enough liver left to live? I reckon I should probably call it a halt there, Joe, because otherwise I'll carry on into another talk, which is another 50 slides.
Well, we can do some questions.
Yeah.
Up on there. So if anyone has any questions for Neil, you can, I guess we can read them rather than flipping over the screen. We'll read out the questions that have been submitted, and then we're going to go to a patient panel after that. Thank you.
Thank you.
Okay, Neil,
Splat.
first question. How many metastatic uveal melanoma patients do you treat annually at Southampton?
I think we were reviewing new patients, about 60, 70 new patients a year that we're looking at. And then we're actually probably treating 30 or 40 of those. So we're giving quite a lot of second opinions. Yeah. So 1 or 2 a week. Yeah. It's about that. Yeah.
Have you got any opinions on stopping things
Sorry,
like...
would you mind repeating that?
Sorry.
Lisa?
Have you got any opinion on stopping things that affect the liver, like statins or alcohol, before treatment of any sort?
Yeah, it does depend what
Can I
you've got
remove your
lined up
patch?
for you. You've always got to get balance in life. Statins are pretty harmless. So I don't ever tell patients to stop your statins.
But the statins actually prevent the liver producing the cholesterol, doesn't it?
They don't interfere with anything that we do to it.
Okay.
So statins are pretty harmless. If you're on St. John's wort or something like that, definitely stop it. There's all sorts of herbal things that aren't great for the liver, often peddled as being good for the liver. But unfortunately, there's no herbal remedy out there that purifies the liver, all your milk thistles and stuff. That's just money down the drain, I'm afraid. You can make your liver healthier by reducing the level of fat in your diet. Sometimes if patients have got very fatty liver, perhaps an obese diabetic patient, we put them on something called a milk diet, which cuts out various types of saturated fat. And you can find the liver shrinks really, really quickly, even within 2-3 weeks. Makes it much, much easier to operate on. Lose a lot less claret. So there are things that you can do to manipulate the liver. They won't change established cirrhosis and scarring of the liver, but they can help reduce liver fat quite drastically, quite quickly.
Yeah, tomorrow.
Yeah.
Reading it out. Oh, here you go. Just nice and close.
Hi, Neil.
Hiya, Claire, isn't it? Yeah.
It is, yeah.
Yay.
Oh, yeah. Does trauma cause Mets to the
No,
body?
it doesn't cause Mets.
Can it reduce?
The only thing it does, major trauma reduces your immune system. It's anything that's a major hit to your immune system will give you a period of susceptibility. So that can be emotional stress, a bereavement in the family, a divorce, big house moves, changing job, all those things. Put all those life stresses together, your immune system will not be functioning quite as well as normal.
What about physical trauma?
And same with physical trauma. So that can be big operations, it can be chemotherapy. That's the surprising two-edged sword of chemotherapy. Chemotherapy kicks your immune system for a bit, unless you're having immunotherapy, in which case it does the opposite. But conventional chemotherapy, because you're damaging your bone marrow and your white cells, your immune system isn't great for a bit. It's not as bad as if you're having long-term immunosuppression. So say you're a kidney transplant patient, then that's the drugs that allow your body to accept somebody else's kidney also allow tumour cells to run rife. So that's one of the reasons we very rarely use transplant for management of cancer, because the drugs that we then have to put you on, unless you've got an organ from an identical twin, we're going to have to put you on lifelong immunosuppression. And that means that any cancer cells elsewhere in your body will just have a party. Yeah.
I've got a few questions from
Yeah.
the room on slide, so I'll just read them out. Is there an advantage to having MRI with contrast?
There used to be, and now there isn't. So there's different types of contrast, and some of them have been withdrawn from use. So we used to use Primavist and Resevist a lot for various reasons. Those have been withdrawn, minimised. We've still got a little bit of Primavist in stock, but they're basically, they've gone. They were liver-specific contrast agents that used to be extremely useful. The contrast that most people use now is gadolinium, and gadolinium goes into the blood vessels, and it helps differentiate the vascularity and blood flow in tumours. And it's useful, but it's not essential. So from a surveillance scan point of view, we've now moved to just doing diffusion-weighted imaging. So this is part of the art as well as the science of an MRI, is actually knowing how to get the settings right. So diffusion weighting, most MRI scanners have been able to do it for a long time. They just needed the software upgrade to ensure that it was available. But basically, it is a way, again, of showing abnormal tissue, highlighting it amongst normal liver cells. And it's very, very good for uveal melanoma because of the melanin in it. It makes a real difference to the way these show up. So we've moved over the last couple of years. Liverpool were the first to do it, but we've followed them to saying for the majority of situations you don't need contrast. You just need a good diffusion-weighted scan. But if you then find probable metastases, you might want to then switch to using gadolinium to try and highlight any more tiny ones that you're missing, and to try and then look at their relationship to the blood vessels and structures in the liver. Okay?
A possibly linked question is 1.5T versus 3T scanners.
Yeah.
Which is best for early detection of mets, and should we be given an option?
Yeah, most scanners are around a 1.5T to 2T. T being Tesla. And I don't know what a Tesla is apart from a car. But the latest scanners are 3 Tesla scanners, and some places have even got 4.55 Tesla scanners. So scanners are improving all the time. You don't want to be on a half Tesla scanner from 1998. 1.5 Tesla scanner is going to work for most people. But it will move in 10 years' time. Nobody will be having a 1.5 Tesla scan. Everyone will be on a 3T, and they'll be talking about 6T, 9T, 12T. It just always moves on.
Last question. How can those of us who are offered ultrasound only ensure the reading of the result is tip-top? And what questions should you ask your ultrasound practitioners to know if they are sufficiently competent to assess UM-related metastasis?
Really, really hard. If they've got lots of acne and look like they're probably only about 23, they're probably, no, it is very hard. I mean, in Sheffield, for instance, they've got a really good ultrasound unit that have got radiologists who maintain their interest in ultrasound and are specifically interested in looking for uveal melanoma mets. I think they've got high pickup rates, and when you've got that situation, then fine, it works. But if you're reliant on one good radiologist and he's gone on holiday or he's off sick, he's not taken sabbatical, then somebody else is going to have to do it. And then it's the question of the art as well as science. So the other option is MR, and it does have the advantage of being reproducible. It gives images that are consistent, very easy to give a second opinion on and compare. Whereas ultrasound is a blurry old fuzz, and the reality is that it's a dynamic investigation, and it requires those moving images and the radiologist having the feel for it. And it's a much more art-based modality, but can be very good in the right hands. However, I think for the majority of scenarios, you would really want an MRI every 6 months. In an ideal world, maybe every 4 months. Yeah. We have had the odd patient at 6 months catch us out where we've missed things and they've progressed quickly over 6 months. Very few, but literally 3 or 4 over the last 8 years.